So this is the 4 pillars of personal injury case management. And essentially this is the outline of how to manage a personal injury case. So there's 4 major categories within personal injury case management. So let's walk through that. So the first pillar is, and this is essentially how the narrative reports and depositions, whether you're in a deposition, a court of law, your narrative reports, this is how it'll flow, essentially. So the first pillar is establishing cause and effect. And of course, that's in the history. So when you're taking history, we definitely want to be able to make a educated, assertive opinion, whether it's in a report, a narrative, or a deposition, that this injury or this accident caused that injury. So you have to establish cause and effect. Now, the more evidence you put around it, the greater the relationship of cause and effect. So that's the first objective, is to establish that this injury, this accident, caused that injury. Now, we have a complete video series of the consultation and the mechanism of injury and cause and effect. But in short, some of the main factors are the position of the patient in the vehicle, the what seat they're in. That will affect the magnitude of an injury a lot of times. If they have a seat belt or not, that affects the injury and liability. The speed of the vehicle, the weight of the vehicle. Now we're talking about mass, force, acceleration, and mass. So that's important to know, the mass, the force of the vehicle, mass times acceleration, force. So that's the force. And then what did the vehicle impact? Did the vehicle impact something, or did something impact the vehicle? And then what direction, left, right, front, back? What was the anatomical position of the person when the impact occurred? And the main purpose for that is to see if joints were locked out. If joints were locked out upon impact, remember, joints go through 3 ranges of motion. There's the active range of motion, passive range of motion, joint motion, and then anatomical failure. So the closer the person is to having that joint locked out, the closer they are to passive range of motion or into joint motion, when the force starts, the higher the likelihood of anatomical failure, sprains, strains, broken bones, things of that nature. So that's important to know. So the direction, so these are factors that I'm going to be getting in my consultation, and these are the purposes of why I'm going to be getting them, is to establish cause and effect. Now, I'm going to also see where the impact was. Not only were joints locked out, whether it's their neck turned or whatever, their elbows or shoulders, because that's what I'm looking for, were joints locked out. That's why I'm checking positions of the body. And then what type of material did they impact? Did they impact anything in the car? Did they impact something hard, something soft? That's also going to help me to establish not just cause and effect, but the degree of force also. So these are some of the main considerations. And again, I have a separate video that explains these in great detail. Now, that's the first important factor, is establishing cause and effect. And that's with the mechanism of injury, and then supporting it with the history and the reports, the accident report. Now, from there, we go to the second pillar. The second pillar is the objectification of an injury. And when you objectify injuries, you have to use science. You cannot use, and you do not want to use, chiropractic, shall we say, diagnostic and type of test, and because everything is science-based. And there will be, in other words, is it accepted? Now, whether you like it or not as a chiropractor is not the point. The point is whether the jury accepts it. And the jury really doesn't care about a chiropractic philosophy. And what's important is credibility to a jury, credibility. And factors that affect credibility has it been written about in medical journals? Has it been accepted in medical journals? Is it in common use in hospitals? Things of that nature. So I never used voyeur science that a lot of chiropractors use. I'll give you an example of when I say voyeur science. In other words, junk science is what it's called. Junk science in chiropractic commonly is a neural calimeter. It's not reproducible. Neural calimeters are highly variable with interprofessional people and settings. It's not accurately reproducible at all, and it's easily disputed as junk science in a court of law. Another example would be the subluxation station. That's junk science. Okay, surface EMGs is junk science in the court of law of what's accepted. As a matter of fact, that's not even accepted in the AMA guides, surface EMGs. So thermographs, thermography, that's highly variable. That's junk science. Okay, so these are all things that can really hurt your credibility if you come in with what's called junk science. So I was very careful when I put my cases together that we only used what the standards of the day, what is being used in medicine and hospitals, in healthcare of the day, and that is written up in the medical journals. In other words, I didn't want them to be able to cast any doubt on me as a chiropractor, because you're already at enough doubt coming into the case, unfortunately. So we're talking about the objectification of the injuries. Now, let me make this simple. There's really 4 injuries that you're going to be dealing with in personal injury. There's 4 core injuries. They may have some residuals, etc., but there's 4 core injuries. And those injuries, and they're in this order, and this is based on the Insurance Science Institute. In other words, the insurance industry evaluates, what injuries are there, the number of injuries, the volume, and all that stuff. So this is right out of the Insurance Science Institute. And so the number 1 injury is a soft tissue injury. 87% of accidents are soft tissue injuries. 87%. The second injury is the disc injury at 32%. So 2/3 of people in an accident do not have a disc injury. The next injury is the neuropathy at 16%. So more than 80% of the people do not have a nerve problem after an injury. And 10% is a concussion. So that's the percentage. Those are the 4 major injuries that you're going to be dealing with in personal injury. And that's the percentages of the injury. There's many reasons to know that. One of the main reasons is there's many patients out there who do not have a disc injury, like this patient that I gave an example of earlier. The first big court case I was in, she had no disc injury and no neuropathy. So most cases do not have a disc injury or a neuropathy or a concussion. So what does that really mean from a marketing standpoint? It means that there's a tremendous opportunity for the chiropractor, because the vast majority of them do have a soft tissue injury, but they won't have a disc or nerve injury. So that's a perfect placement for the chiropractor. There's a huge segment of the market right there. Now, let's go into the objectification of these injuries. So I'm going to go backwards a little bit here, because we need to spend a little more time on the soft tissue injury. So when we go backwards, when we deal with the concussion, now you do not have to interpret concussions. I mean, the key is to be a manager, not just a facilitator, but you're a manager of the case. So if you suspect signs and symptoms of a concussion, you want to make sure it's sent out to a neurologist to make sure that that is documented with a high authority case. Now, that's why you need a medical team. There's a separate video I created that tells you who you need on your medical team and why. So you need to get your medical team together. When I say medical team, I'm talking about people that you have met in agreements with, that you've explained to them what you do, and essentially they do a couple things. Number 1 is they accept your referrals. Number 2 is they don't say anything bad about chiropractic, and they don't take them off the treatment schedule. So those are the agreements. In other words, they don't interfere with me as a healthcare professional, and I don't interfere with them as a healthcare professional. Those are the basic agreements. If they can't do that, they're not on my team. So I make sure I have a consensus team. So I would make sure I'd have a neurologist on my team to evaluate potential concussions if I have any signs or symptoms of concussions. See, now I have the authority of the neurologist with a concussion. That's going to be way more of an authoritative figure than you as a chiropractor. Then also coming up in the injury is the neuropathy. So I want to make sure I have a neurologist that can run EMGs, NCVs, and some electrodiagnostic brain work for any potential radiculopathies or nerve dysfunctions or symptomatology. So remember, I'm always going to have greater credibility. So do I have to know the details of concussion? No. Do I have to know the details of neuropathy? No. I have to know how to be a manager. That's one of the big characteristics of being an effective doctor in personal injury, is knowing where to send the patient to the highest specialist for that particular injury. So that's the neurologist for the NCV or EMG, and those have to be documented for you to have a neuropathy in the AMA impairment guides. That has to be documented through electrodiagnostic studies. Okay, so you can't use junk science for that. So that's the neurologist with electrodiagnostics. Now, the disc injury obviously is the concussion, or the MRI or the CAT scan. So, and also one consideration is stress MRIs. Stress MRIs. In other words, putting the spine. Let's say if it's the neck in flexion or extension, especially flexion, if we're suspecting a posterior type of injury, to stress that anatomical tissue to accentuate the injury or to see it. And a lot of times you can see it as much as 20% or 30% more of an injury if you stressed it and took the MRI. And you can order it that way. All of these tests you can specify modifications in. You can order a stress MRI and tell them you'd like to have it in a forward flexion position and etc. So the MRI, and of course that's typically, I like to use the neurosurgeon. I order the MRI myself because that's a radiologist that's going to read it anyway. So it's a totally objective, and it's a neuroradiologist that's essentially going to read it anyway. So that's the objective documentation of those three injuries. The one injury that a lot of chiropractors aren't familiar with, that there's a tremendous confusion around, that has the greatest value to a chiropractor in personal injury, is what's called AOMSI, alteration of motion segment integrity. And that's essentially a spinal ligament injury. Now that injury is a very valuable, it's a bad injury for the patient, meaning it's a very valuable injury for financial reimbursement. And that's a soft tissue injury. So the orthopedist or the neurologist, they don't check for that, and they generally don't even know about it. So the AOMSI, and there's a separate video that I explain the details of AOMSI, but you have to know this. This is where the AOMSI is the bread and butter of chiropractic and personal injury. That's the core of chiropractic and personal injury right there. Everything else is supportive of that. So you have to be very familiar with AOMSI. Now, let me talk a little bit about that. So when you get the AMA guides, you can look up the AOMSI. You can look it up on the page, and it's only a page and a half of material. It's not hard, but it gives up to a 25% impairment rating. So it's a high impairment rating. Now, what I want to point out in this particular video is just because the person has an injury doesn't mean they have AOMSI. Like in the neck, if there's a certain amount of angulation or translation, that means there's a ligament injury that's creating instability in the spine. That's AOMSI. And they're measured. They're measured. And they're typically measured with what's called CRMA, Computerized Radiographic Mensuration Analysis. It's a big word. And all it means is it's a digital form of measuring. That's it. Now, when I had that case, that was in the 90s, and that was before the internet. So there was no digitization back at that time. All I did is I measured it myself. I just took my ruler, drew my lines of mensuration, and then measured the amount and went to court with it. That's how I measured AOMSI. That's how I measured angulation or translation. So you can easily just draw lines yourself and do it. But the good thing about CRMA, computerized radiographic mensuration, is when you have an x-ray, it's as simple as taking an x-ray, then a flexion extension x-ray, and digitizing it, and then putting it into a software program. And basically now you just mark landmarks on the anatomy of the spine, the superior vertebra, the tip, just different anatomical parts. And then the software program creates the angulations, and it measures. So it gives tremendous third-party objective quantitative data, which is very important. Objective is hugely important in personal injury. Third-party objective evidence is huge. So it gives the measurements of what is considered normal and what is abnormal, and then it will also say if it's gone far enough to actually go into AOMSI. So if there's enough of a translation or angulation, whether it's in the low back or the neck, then it goes into what's called AOMSI. Now, what you just need to be aware of is, and I'm going to use some rough numbers here, but there may only be 30%, no more than say 40% of your soft tissue injuries that actually fit the criteria, the definition of AOMSI per the AMA guides. Now, does that mean that you don't have a valuable case? No, not at all. And the reason for that is if from this point forward it's AOMSI, in other words, now it's by definition AOMSI. Well, and let's say it's a 3.5 millimeter translation. Well, what if it was 3.49? Well, as per definition of the AMA guides, it's not defined AOMSI. But does that mean that there's no injury? No, there's still an injury there. So you have what's called now alteration of motion segment integrity, alteration of motions, and that's essentially the same thing as AOMSI, but it's not the magnitude. In other words, when you quantify it, it's not as much, but it shows altered intersegmental motion. And that's what a lot of people miss. Now, once I include AOMS, or altered intersegmental motion, with AOMSI, I'm up to 80 to 90% of soft tissue personal injury cases. In other words, in all the years of practice, it's pretty rare to see somebody in an auto accident take a stationary picture and a motion picture and see their spine actually moving normal. That is highly, highly unusual and rare. Now, most of them will not have AOMSI, but the vast majority of them will definitely have alteration of motion segment integrity, and it's still an impairment rating, an impairable rating. It's just not per definition of AOMSI. So that's why it's called the guides. So you can still give it a 15% impairment, a 10% impairment, 20% impairment. You just can't give it the impairment that the AMA guides registers that's tied to AOMSI. And that seems to be a huge point of confusion with doctors when I talk to them. So I did create a total separate video that explains the difference between AOMSI, altered intersegmental motion, and how it's documented. So you definitely need to be sure and familiar with that. So I guess what I'm saying in a nutshell is, out of the 4 major injuries, the soft tissue injury is by far the greatest injury, number one. Also, as a specialist, the chiropractor is the only specialist that can compete from a marketing perspective, because the chiropractor not only deals with soft tissue injuries, the chiropractor deals with active range of motion, passive range of motion, and joint motion. Orthopedists don't deal with that. Neurosurgeons don't deal with that. Physical therapists really don't deal with that. So from a marketing perspective also, that's where the chiropractor wins hands down. It's easy for me to gain authority and influence and beat out an orthopedic surgeon and neurosurgeon if the topic is ALMSI or altered intersegmental motion. It's going to be very difficult for me to beat out a neurologist or an orthopedic surgeon when it comes to a disc rupture or altered NCV. They will have way more credibility and authority. That's very important from a marketing perspective. So that's a key component in, so almost all the patients you have, even if they do not have a disc injury or a neuropathy, they will almost always have altered intersegmental motion, even if they do not have alteration of motion segment integrity. What I just said is major. Now, let's go to, that's the objectification. That's the objectification of the core injuries, the 4 core injuries. So let's go to the next pillar, which is the therapeutic protocol. So your treatment should be based on the 3 phases of healing. In other words, what phase is the person in? That's the therapeutic protocol that you should be using, whether it's to reduce pain or inflammation. That's why you should be doing what you're doing. If they're in the repair phase, you should be familiar with the repair phase of healing. That's your therapeutic approach and your protocol. And the same with the remodel phase. So you're justifying your therapeutic approach based on several factors. The first and absolute most factor is the 3 phases of healing. So you absolutely have to be familiar with the 3 phases of healing. Again, I created a separate video that explained the 3 phases of healing, and really to the degree of which you have to know it. You don't have to know it on a microscopic level, but you have to be familiar with the language and the basics of what happens and how it happens. So that is a separate video likewise. So the therapeutic approach is based on the 3 phases of healing. 1, 2, the patient's response to care. Now, that's a major factor. So how are we documenting this? Well, you know, we did the objectification through the consultation and the examinations, right? That's how we did the objective findings as well as the tests. We did range of motion, muscle testing, reflex testing, orthopedic testing, maybe an MRI, maybe a ALMSI. So that's how we found these tests. And some of those are way more objective and confirmatory than some of the other ones. Some of the least effective are obviously the subjective symptoms that the patient says. Those are the least effective. The most effective is a totally objective visual diagnostic test. That's the most authoritative. That is refereed. In other words, it's standard and accepted in the medical community. So when we're back to the therapeutic approach is the third pillar of case management. So we have to consider the phases of healing, 1. Then we have to consider the response to the patient. Now, what does that mean? It means re-exams, and it means SOAP notes, and it means indexes. So most people, chiropractors, are familiar with SOAP notes. You have to have SOAP notes for your daily. Most chiropractors are familiar with re-exams. Most chiropractors are not familiar or are not doing indexes. When I say indexes, I'm talking about the standard indexes that are routinely accepted, such as the Oswestry scale, the neck disability index, so the low back index. So you have to use an index. And indexes are for quantifying functional capacity. That's what indexes are for. They help correlate the subjectivity of the patient, the subjectivity with the functional capacity. Those are called indexes. So you want to definitely use your indexes in your re-exams. You would do an index in the beginning. You would do an index in your re-exam. Indexes are not done every day. They're just done in the beginning and at each interim re-exam. Those are called indexes. Okay, now, so it's the patient's response to care. Based on the treatment protocol should be based, in other words, what are you doing physiologically, therapeutically, should be based on the 3 phases of healing. You should be able to explain. If you're doing muscle stim, you should be able to explain why you're doing muscle stim relative to what the symptoms are, subjective and objective, and more importantly, what phase of healing they're in. That's how you should be able to explain your therapeutic approach. Now, the next one is we talked about phases of care. We talked about the indexes. So you're doing your SOAP notes and then your re-exams. Your re-exams should be done every 12 visits. Every 12 visits, especially if you're seeing them 3 times a week, twice a week, or once a week, something like that. Every 12 visits, you should do your re-exams to quantify and measure and check the trend line. Is the patient getting better or worse? Do you need to change your therapeutic approach? Maybe you need a second opinion. So that's the purpose of the re-exams, is for continued improvement or modifying the therapeutic approach. So, or if they're progressing as expected, staying as expected. But now you have the justification of your therapeutic approach. That's not only important for reimbursement, that's very important to win a case. So that's the therapeutic approach. So you've got the 3 phases of healing. Now remember, we're talking about the 3rd pillar. That's a therapeutic approach. That incorporates the 3 phases of healing. It incorporates the subjective and objective examination of the patient. It includes the SOAP notes, includes the re-exam, and it includes the indexes of that particular anatomy. That's what you want to include. So that's the therapeutic approach. Now, let's go to the 4th pillar. The 4th pillar is the prognosis. The prognosis. And there's 3 main components to a prognosis. The prognosis is basically summing up the case. And the prognosis is in the narrative report. So, and it's very, very important. Now, I do have a separate video that goes into a deep dive of the 3 components of the prognosis. There's 3 main components of a prognosis that you have to include in your prognosis. So, obviously in the prognosis, we want to include the cause and effect. We want to say specifically, this injury caused this accident caused this injury, and why. Number 1. Number 2, we specifically want to talk about their therapeutic approach and their response to treatment and their impairment rating. If they have an impairment rating, and in all likelihood, they're going to have an impairment rating. So you're going to want to include that. The in regards to the so that's number 2 is the therapeutic approach, response to treatment and impairment rating. So you're substantiating how the patient responded, and it's all documented with all the accepted indexes and documentation. And then the last one is future care, the prognosis, future care. Those are the 3 components of a prognosis. And future care, and people get confused with this and they go, wow. Well, first of all, let me say, how important is future care? Well, future care is one of the major financial drivers in a case. The amount of care somebody's going to need because of this injury is added into the value of the case. So if the patient is 25 years old and they're going to need, some type of care, let's say chiropractic care, once a week, well, they'll take that estimate of 25 years old until the present day index, the actuarial scale of that person's death. They'll take that number of years that equals the number of weeks. If you were able to substantiate that they needed care at least once a week, and then you explained what care they would need therapeutically, then they would ask, what would that cost? So in simple terms, let's say they would just need an adjustment once a week and it's $50, and there's X amount of weeks till the rest of their life. Well, they take $50 times X amount of weeks, and that's tied into the value of the case. So 2 of the major categories of financial compensation of a case are the injury itself and future care. So documenting the injury itself is vital. The ability to explain scientifically the need for future care is vital. Now, future care is, and this is explained in the separate video on the prognosis, future care essentially is based on present care. So I'm going to be treating a patient until they're no longer, remember the definition of an impairment is no greater improvement subjectively or objectively over a 12-month period. Okay, so, and each state can vary in their definition, But essentially, that's the AMA Guide's definition to impairment. And that's based on the 3 phases of healing. After you get out of the remodel phase of healing, your healing's done. So that's what it's based on. So the future care, how could you estimate future care? It's based on essentially where the patient's at right now. Because you would have treated the patient up to a certain point over a certain time period. And generally, I say 2 re-exams. So if they're in the remodel phase and they've gone through 2 re-exams, in other words, 2 12-visit periods, that's about the time period that I would be comfortable giving an estimate of an impairment in future care. Now, you can give the impairment anytime you want, but by definition, it is generally more accepted after the person's essentially healed all the way. But you don't have to wait. Now, you're obviously going to have less of a credible impairment rating if you do it 1 day after the injury. That's not going to be very credible at all. So I always say, don't do an impairment rating in the repair phase. Don't do an impairment rating in the inflammation phase. Don't do an impairment rating in the repair phase. Do it in the remodel phase, and preferably it would be toward the middle end of the remodel phases when you want to give your opinion, because then you're going to have higher percentage of accuracy, especially if they've gone through 2 re-exams based on when you do re-exams, and there's no subjective or objective improvement. Now I have a lot more credibility in saying this is the permanency. Now, once I'm at that point, the patient has been on that schedule, say for 3 months, 2-3 months. So in other words, we've treated them in the repair phase, and we've done the different therapeutic approaches. We were responsible and referred them out to corresponding physicians or alternative providers to assist in the management of the case, but the patient is not responding anymore. That's called MMI, maximum medical improvement, and now we can tie in an impairment rating to it. Now, so how can I project this person into the future with prognosis? Well, at that particular point, their treatment schedule would be based on need. So in other words, I would have been communicating with the patient, whether I saw them once a week or once every 2 weeks or once a month. And now we'd be kind of at the point of in other words, it's more symptomatic. We're not going to structurally change anything. We're done with or close to being done with the 3 phases of healing. And now it's really just symptomatic relief with the patient. So I would have already had a window of at least 2 months of no change in subjective or objective findings. And let's say if the patient was once every 2 weeks in that category, well, I can easily make the relationship in a deposition in the court of law by the patient's history. That is, I can say, going forward, that's what they would need, 1 treatment every 2 weeks, because that's exactly what they have needed up to this point. And that's how you substantiate and project. And a lot of doctors are confused about how to project need of care. Well, I just explained how to do that. So that concludes the prognosis, the 3 components of a prognosis. And again, we have videos that go into great detail in each of these subjects peripherally and go into great detail of each of these subjects.